I'm Dr. Brian Haas. I'm the National Medical Director at Ascend Hospice and founder of Hospice Intelligence. Every hospice clinician I've worked with leads with compassion. We see suffering, we witness decline, and we document the care, hoping it will be enough. But what feels like enough to us often isn't enough for a Medicare auditor, especially when that auditor may not have a clinical background. Many Medicare auditors are not medically trained. They aren't nurses or physicians. They're tasked with comparing documentation to rigid criteria, not interpreting clinical nuance. That's why clear, objective alignment with LCD benchmarks is so important. So that's where these LCDs, or local coverage determinations, come in. LCDs are Medicare's roadmap. They help determine whether a patient's prognosis is 6 months or less. Each major condition, like pulmonary disease, cardiac disease, or Alzheimer's, has its own set of LCD benchmarks. And when disease-specific criteria don't apply, we fall back on general decline markers: weight loss, reduced function, increasing dependency in ADLs, wound development, and changes in PPS. The problem is many clinicians document a compassionate and accurate story, but they don't anchor it to an LCD. And when CMS reviews that chart, it doesn't matter how real the decline is, it matters whether it's measurable on paper. So, I want to walk through 5 of the most common LCD pitfalls and how to avoid them. First, the narrative without evidence. I've seen CTIs say things like, this patient is declining. They have heart failure, they're tired all the time, they've been hospitalized recently, and the family wants comfort care. I believe they have less than 6 months. Now that sounds somewhat reasonable as a clinician. I trust the words of another clinician. But for CMS, it's not enough. You need objective data. If they've declined in function, show the PPS change. If they were at 50% and now they're at 40%, describe how. Maybe they used to transfer to a chair and now they're bedbound. Maybe they've gone from needing help with 4 out of 6 ADLs to 5 or 6. Spell it out. If the patient has lost weight, describe it. They have temporal wasting, they have baggy clothes, visible ribs, temporal wasting. Don't just say appears thin. Paint a clinical picture with details tied to those specific LCD criteria. Second, skipping general decline when the diagnosis doesn't fit a disease-specific LCD. Not every hospice patient has cancer or advanced heart failure. Some have Parkinson's, advanced frailty, or multi-system failure. That's where the general decline checklist becomes critical. Use it. Don't just skip it because there's no clear diagnosis to match. The general decline LCD includes measurable indicators like weight loss of 10% or more over 6 months, or 5% or more over 3 months. It includes development of wounds, poor response to optimal medical therapy, and increased dependency on 3 or more ADLs. A palliative performance scale, or PPS, of less than 60% is another major indicator. Recurrent infections such as pneumonia, sepsis, or pyelonephritis also support hospice eligibility. These are not vague red flags. They are clearly defined markers that must be documented explicitly. When you see these changes, capture them. Show that trend. Use clear, concise language that aligns with what Medicare reviewers are trained to look for. This is exactly what Hospice Intelligence is designed to help with. You notice the clinical change. Hospice Intelligence helps you board it correctly. It bridges the gap between your bedside assessment and what CMS needs to see in writing. Third, you may use outdated or static assessments. You might have nailed that initial CTI, but if the research isn't just repeating the same note or shows stability, CMS may say, they're no longer terminal. So you need to use comparative data, track their weight over time, show increasing oxygen needs, note new infections or hospitalizations, highlight worsening function. Your goal isn't to reprove the initial eligibility, it's to document the continuation of that decline. Fourth, functional scores, or missing them for more important reasons. This is a really big one. Tools like PPS, FAST for dementia, New York Heart Association classes for CHF are often left out entirely or added inconsistently. Now, these are not optional. They're how CMS objectively gauges decline. Include them in every CTI. Standardize it. Fifth and final, Over-reliance on comorbidities. I get it, your patient has diabetes, prior strokes, atrial fib, COPD, and that's certainly important context. But none of those justify hospice by themselves. Use comorbidities to reinforce decline, not to stand in for it. Show how those conditions accelerate the trajectory of the primary terminal illness. So, what do we do with all this? I created Hospice Intelligence because I saw how hard it is to balance clinical care with Medicare compliance. Our software uses real-time AI and LCD checklists that guide nurses and physicians through what Medicare actually wants to see, without making them dig through policy manuals. Because the truth is, most hospice teams are giving the right care. They just need help showing it in the right format. Let's end with this. LCDs are not the enemy. They're the framework. They're how we keep the benefit protected for our patients and for our teams. So yes, let's lead with compassion, but let's document with clarity. If this video has helped you, give it a like, drop a comment, or share it with your team. You can learn more about Hospice Intelligence at hospiceintelligence.com. And if you want to chat directly, I'd love to connect. Let's elevate the standard together.